Assalamu alaikum. Today our topic is ectopic pregnancy. It is an important exam question frequently asked. We are going to start the topic with this scenario so that you can have a better understanding of what type of questions are asked and how the scenario is given. What are the important points to note in a scenario and how you can get an idea of what the scenario is about from the scenario. Okay, this is asked in 2018 annual KMU in KMU past paper. This is from KMU past papers. A patient present with 5-week gestational amenorrhea. Okay, gestational amenorrhea, that she may be pregnant, having pain in the lower abdomen. This is one of the common sign of ectopic pregnancy. PV spotting, again a common sign of ectopic pregnancy which we are going to study. Urine for pregnancy test is positive, so her amenorrhea is gestational amenorrhea. This is confirmed that she is pregnant. Okay, she is pregnant, her urine for pregnancy test is positive, but ultrasound shows no evidence of gestational sac. Look, now this is a very clear scenario. This scenario is very clear that she has pregnancy test is positive, but ultrasound show no evidence of gestational sac. So serum progesterone and beta hcg are done. Her tests are done. What progesterone level predict normal pregnancy? We will study these in the coming few minutes, inshallah. At what beta hcg level would an intrauterine pregnancy can be seen by transabdominal ultrasound, and drug used for medical management of ectopic pregnancy? We are going to study all of these in the coming few minutes. So what is ectopic pregnancy? Ectopic pregnancy is defined as implantation of a fertilized ovum at a site other than uterine cavity. Okay, when the fertilization has occurred at a site which is not the uterine cavity, that type of pregnancy is known as ectopic pregnancy. Here focus on the diagram. If anywhere, if the pregnancy has occurred, if the implantation has occurred anywhere outside the uterine cavity, may it be the cervix or the fallopian tube, the fimbria, the ovary, the abdomen, but if it's not the uterine cavity, the fundus or the body of the uterine cavity, that pregnancy is known as ectopic pregnancy. Okay, what are the sites of ectopic pregnancy? Now, fallopian tube is the commonest site of ectopic pregnancy, and it accounts for 95% of all cases. So sometimes we also refer to fallopian tube as tubal pregnancy. Okay, if anywhere the word tubal pregnancy is used, you should not get confused, because in many of the scenarios and in many of the books or lectures, it is ectopic pregnancy is sometimes referred to as tubal pregnancy, because 95% of all the cases occur in the fallopian tube. Within the fallopian tube, ampulla is the commonest site. Okay, why? Because under normal circumstances, the fertilization occurs in the ampullary region, so it is the commonest site, and almost every pregnancy starts in the fallopian tube. What is the normal mechanism here? I would like to focus on the I would like to tell you some points here so that you can have a better concept. Look, from the ampullary region, the fertilized fertilized ovum moves medially to enter the uterine cavity. Okay, and it takes a time of 3 to 4 days, and then it finally implants in the uterine cavity. Then there are a number of factors which are involved in this transport mechanisms. These includes the contractions of the fallopian tube, muscular contractions, ovarian hormone like estrogen and progesterone, and the movement of the cilia present in the fallopian tube. So any alteration in any one of the function or any one of the factors will delay the transport of zygote. Okay, and when the transport of the zygote is delayed due to any of the factor, it begins to enlarge. This is very understandable that after some time its division will start, and it continuously enlarges, and the pregnancy will get obstructed and implanted in the ampulla or medial to it. And sometimes the fertilized ovum may move laterally, and the pregnancy is either implanted in the fimbrial end. If it has moved laterally, it may implant in the fimbrial end, which is the second location which you should know, or fall into the peritoneal cavity, okay, leading to abdominal pregnancy. And it may fall out of peritoneal cavity, leading to tubal abortion. Okay, so these are the three sites which I have told you. Fallopian tube. In the fallopian tube, the ampullary region is the commonest region, then may occur in the fimbria, then abdominal pregnancy, and abdominal pregnancy. Abdominal ectopic pregnancy occurs in 0.03% pregnancy. Ovary is the second commonest site of ectopic pregnancy and responsible for 0.05% of the pregnancies. Okay, and ovum. Then moving on to the what are the rarest sites? The rarest sites are the cervix, the vagina. The look when really the zygote may slip. Okay, how does the zygote reaches the cervix and the vagina? Rarely, the zygote may slip through the uterine cavity and get implanted in the cervix or even the vagina. And other rare sites are broad ligament and rudimentary horn of the uterus. Okay, then moving on to what is heterotropic pregnancy. What is heterotropic pregnancy? Again, a question asked in many places. Heterotropic pregnancy is an ectopic pregnancy, okay, general tubal pregnancy and ectopic pregnancy, which coexist with a normal intrauterine pregnancy. When it is called as heterotropic pregnancy, there is combined tubal and uterine pregnancy. This is known as heterotropic pregnancy. Moving on to the etiology of ectopic pregnancy. What is the etiology? First of all, the first cause is pelvic inflammatory disease. It is the most important etiological factor of tubal ectopic pregnancy. Whatever may be the causative organism, okay, what is the cause? Whatever may be the causative organism, tissue damage from the pelvic inflammation removes the ciliated epithelium. These are the ciliated epithelium which I have drawn. If a disease has occurred and it has damaged the cilia, if the cilia is absent, it may disturb the movement, okay. The ciliated epithelium within the tube and peristaltic action is impaired, which slows down the transport of fertilized ovum, okay. If these are destructed, the movement of the implanted zygote is disturbed, and it begins to enlarge inside, and it starts growing and obstructing the fallopian tube, and ectopic pregnancy occurs. And in severe cases, the inflammation results in intratubal adhesion, forming and creating glands like spaces, and the fertilized ovum may get trapped in the spaces and implant, meaning that if here a space has formed and the fertilized ovum may get trapped here, and still leading to ectopic pregnancy. What is the second cause? When a patient presents with history of previous ectopic pregnancy, okay, one prior pregnancy increases the risk of ectopic pregnancy by 15%, and two prior pregnancy increases the risk of ectopic pregnancy by 30%. Then what is the other cause? The third cause is tubal surgery. Previous tubal surgery when a patient okay, this is an MCQ. Which of the following the risk factor gives highest risk of ectopic pregnancy? So previous tubal surgery, this is the answer. Now the first surgery is when a conservative surgery is done for ectopic pregnancy. Look, when a patient with tubal ectopic pregnancy is treated with conservative surgery, the affected fallopian tube is repaired and the incidence of subsequent tubal pregnancy is markedly increased. Sterilization, when bilateral tubal ligation is done for sterilization through a permanent method of family planning, it may sometimes fail. Okay, and this failure may occur due to spontaneous recanalization of the tube if the lumen is not completely occluded at primary procedure. The latter is more commonly seen when clips are used. So the clips may open or canalization may occur, and it will lead to tubal pregnancy. And then tubal reconstruction. Tubal reconstruction, the pregnancy subsequent to reconstruction surgery for tubal blockage is at an increased risk of fallopian tube ectopic pregnancy. And when the patency of fallopian tube is established, the lumen remains narrower than normal and the tube wall elasticity is decreased due to the scar tissues. So what are the other causes? Tubal diseases. Tubal diseases like selphingitis, ischemica nodosa, characterized by formation of small diverticuli in the lumen of fallopian tube, is associated with increased incidence of ectopic pregnancy. Then intrauterine contraceptive devices. The increased incidence is in IUCD is actually due to the association of pelvic diseases with the intrauterine contraceptive devices. Okay, when compared with oral contraceptive pills, note here that when the patient is taking an oral contraceptive pills, so both intra and extrauterine pregnancy are prevented due to suppression of ovulation, while in IUCD predominantly prevents intrauterine pregnancy only. Okay, the uterus is blocked and the patient may present with ectopic pregnancy. Then diethyl stilbestrol exposure. The patients exposed to diethyl stilbestrol in their intrauterine life develops uterovaginal and fallopian tube abnormalities. Okay, and which increases the incidence of ectopic pregnancy. Then termination of pregnancy. When the patient comes to you with history of 2 or more termination of pregnancy, they are at an increased risk of ectopic pregnancy. Then assisted reproductive techniques such as ovulation induction, IVF, GIFTs and ZIFTs are all associated with higher incidence of ectopic pregnancy. And what are the DDs? This is also past paper questions, that what the scenario is very clear, but and you have guessed already that the scenario given is up for ectopic pregnancy, but they ask you that what are the differential diagnoses. So the differential diagnoses are spontaneous abortion, especially thread-end abortion, acute pelvic inflammatory disease, appendicitis and molar pregnancies.